So this is the title of my talk. I'm going to talk about chronic pain management. I'm going to touch upon the public health crises that we've been facing and the ones I anticipate we're going to face in the future. I have no disclosures. Here are my objectives. All right. So pain is a normal physiological response that happens after tissue damage. So it's predictable that it's going to happen after surgery, right? And yet, in the era that we live in, where pain has been the fifth vital sense and we've been encouraged to treat pain and eliminate it completely, along that has gone patients kind of expecting that pain is going to pass and they're not going to have any. Unfortunately, that's not true with surgery. And kind of generally across the board, if we look at the surgeries, about 10 to 20 surgical patients are going to end up with some type of new persistent pain after surgery. And for most people who have a pre-existing pain, they're going to continue to have that pain even after surgery. And who are the people that are at risk for either new persistent pain or kind of ongoing pre-existing pain? They tend to have psychiatric conditions, right? So across the board, the robust predictors of pain tend to be anxiety, depression, pain catastrophizing, as well as pain sensitivity. Probably the most robust predictor is being on preoperative opioids, and then oftentimes female gender can be predictive. So this is just one example of one study, but I could show you slide after slide after slide of these types of risk factors leading to chronic post-surgical pain. So why is this important? Well, there are 100 million surgeries in the US alone and over 320 million surgeries globally each year. And as it turns out, surgeons are one of the top prescribers of opioids, at least in the United States. So you can see here from this paper a couple years ago that surgeons prescribe about 11% of our opioids, and then orthopedics separately can prescribe up to another 4 to 5%. And we can say, well, maybe surgeons are prescribing that many opioids just because, again, of the abundance of surgeries. But there's a lot of other factors that influence perioperative prescribing. And that includes that providers might not necessarily follow guidelines, for better or for worse. Sometimes they should, sometimes they shouldn't. There's real inconsistency in opioid tapering in general in primary care practice, but especially after surgery. And I should say this data comes from a qualitative study that was done at the Mayo Clinic, interviewing about 20 providers in the perioperative specialty. And they talk about how their clinical experience or time constraints kind of influence their opioid prescribing, meaning that oftentimes they don't have time to do it. There's also challenges in managing patients' pain expectations, especially for those patients with chronic pain. And then there's no best care practices. So interestingly, patients have surgery, they might get an anesthesia evaluation before surgery, maybe their primary care doctor is prescribing their opioids, the surgeon may take over in the kind of acute, intraoperative and acute post-op period, but then there's no standard of care for who's going to take over the opioids in that post-operative period. And oftentimes it's when the surgeon says, oh, I don't know what to do anymore with your pain, right? Go back to your primary care. But with that lack of standardization, it leads to a lot of inconsistencies and risk of patients ending up on chronic opioids. So, as I just explained, one of the problems in perioperative pain medicine is that there's a lack of standardized kind of pain care pathways. And that's led to problematic outcomes. It can lead to post-surgical adverse events. It can lead to patients ending up on high-dose long-term opioids, and that can delay recovery. So there's a lot of opportunity to improve the system. And certainly our surgical and anesthesia colleagues have done that through these enhanced recovery after surgery pathways that many of us are probably familiar with, where they take a multidisciplinary team in kind of that acute post-operative period and work with patients to get them out of bed, make sure they're eating and pooping and walking before discharge. And that's led to significant improvements in reducing opioids after surgery and reducing complications. But those types of pathways are really focused on a very short time frame. We don't think about the long-term outcomes in those pathways. So my colleagues in anesthesia and I kind of took this opportunity to think, how can we improve the system? And that's where we've kind of developed our own transitional perioperative pain program here at Hopkins. Now, this is a pretty unique program. I think it's one that we can spread across the country and even around the world. But just so you can see here, these red dots indicate that there's a program in Finland. There's a program at University of Utah in the Utah VA health system. The first program of this kind was in Toronto, and then we have one at Hopkins, and there's ones building up at Duke and Vanderbilt. So this is still a pretty unique program, and actually Hopkins is the only place that has the psychiatrist rather than psychologists that are doing the mental health treatment. So many of you probably, if you're familiar with me, know that we've essentially started this personalized pain program. And so that's what we've called our transitional perioperative pain program. So what we did was when we started the clinic, we actually called ourselves the Periop Clinic, and then we did a lot of patient engagement interviews and qualitative studies, and realized that patients don't know what the term perioperative even means. But they did resonate with the idea of a personalized pain program. So fortunately, we were able to change our name from a triple P of perioperative pain program to a personalized pain program pretty quickly. And the idea is simple. It's the idea that ideally we try to capture patients preoperatively, and anesthesia or surgery, anesthesia and psychiatry myself can work with them and the surgeons to optimize their pain management and reduce their opioids before surgery. But most often they're captured by our acute pain service when they're hospitalized right after surgery. And patients who are going to be leaving on high-dose opioids or have a history of chronic opioids are referred to our clinic, where then patients work with us, transitioning from that acute to chronic postoperative care, again with anesthesia and myself. Through a CDC grant where we're focusing on improving patient engagement, again, using patient interviews of what they were hoping for when coming to our program, we were able to design a website and some flyers and brochures, and create some videos to introduce patients to our clinic so they could gain familiarity with ourselves and what our treatment goals are. And you can see the website there if anyone's curious about that later. So who do we see in the PPP? Well, about a third of our patients are African American or Black, a slight majority are female. A lot of our patients have a high school education or less, and most of our patients are unemployed or disabled. I should also add that about patients have been on chronic opioids for about 8 years before they come to see us, and I'll show you the data, but they're on what we consider high-dose opioids too when they come to see us. And we've kind of recruited patients from our orthopedic and trauma surgeons, so that's where the majority of our patients, the incident surgery that they've had. But we see all types of surgeries. In the column, people always ask about the no JHH surgery, and that is kind of the pool of patients who might have had surgery. It's just kind of outside of that preoperative window that we normally think about, or patients who end up having surgery outside of the Hopkins system. So this is a case series that we published in 2022, and I'm always really proud of case series, right? Because I think it shows us some of the individual progress we can make. So our trauma patients can be the most difficult to treat. And one of those reasons is because oftentimes people who undergo trauma have to undergo multiple surgeries. So these are 2 out of the 4 cases that we presented in our paper. The first patient was someone who had a knife stabbing in Baltimore City, and the last person was someone who fell and fractured her ankle at work. And what you can see is in the black lines, these are the MME or opioid doses as they're coming to clinic. And so this person started out about 45 morphine equivalents when they were discharged from the hospital, and then before they came to see us, they were using illicit opioids, so they were doubling their opioid use from illicit purchases, and that's how they came to see us. Now, the red arrows here are the most important points of this slide, because those indicate patients who needed repeat surgeries. And so what you can see is that even though we were able to reduce their opioids, reduce their pain sensitivity and pain interference, reduce their insomnia severity, which is the green, and reduce their pain catastrophizing, the teal, anytime these patients have another surgery, all of those numbers tend to go up again. So this to me says that what we're doing is really, really important, right? Because we're following patients for 6 months. You can actually see here, we're following patients here for 12 months and here for 2 years. So we're helping them through each of their surgeries to prevent them from ending up on really high-dose opioids or really poor outcomes. And then just to clarify for this patient who had the fracture, she was doing pretty well in terms of reducing her opioids. She was only on 45 MME when she was discharged from the hospital, and ended up on relatively low dose, so less than 20 MME, before she had her next surgery for a repeat ankle fusion. But you can see in the blue line, or the teal line here, that right before her second surgery, her pain pain catastrophizing score skyrocketed to the maximum, which is 52 out of 52. And then that improved after she had the surgery. So again, we're trying to help patients along each way with each kind of risk that they have in terms of their quality of life. So one question I've had in terms of our patient care is, well, we think we're doing a good job, but do our patients think we're doing a good job, right? So Divya Manoharan, who's a medical student, a fourth-year medical student, as well as Hannah Flynn, who was a Loyola undergrad, did this study with us. And we interviewed 26 patients who had either completed our program or at least completed the opioid taper and maybe continue to see me. Found many themes involving the importance of patient engagement and shared decision-making and setting patient expectations early, kind of continuity of care with the opioid tapers. But the quotes that I'm sharing right now are kind of about those general perceptions and experiences in this type of clinic. And you can see here, this is similar to things I've reported before, but patients really describe this as a unique experience where they have a long-term specialist, either from anesthesia and or psychiatry, working with them. And they really appreciate having a specialist who's not their surgeon or their primary care doctor helping them. It also provides a lot of ease for family members and those caregivers who also know that someone's going to be managing their partner or husband's pain. And my favorite, of course, as the psychiatrist, was seeing who patients can recognize the value of treating mental health helps pain and treating pain helps mental health. So going back to kind of the crises we've been experiencing in medicine in the world, as we all did, right, during the COVID pandemic, as of March 23rd, 2020, our clinic had to pivot to in-person care to telemedicine quickly. And this is just the graph showing that the number of new patients that came to our clinic did actually not change over the course of pre-pandemic and then during the pandemic. So on average, we were seeing about 16 new patients per month before the pandemic, and we continued to see that during. Okay, this isn't necessarily that impressive, right? Because there's 60,000 surgeries at Johns Hopkins a year, and there's 3 of us faculty member. But the truth is that we still continue that referral process. And I don't expect you to be able to see our demographics, so what I'll just point out is that, so we have 3 groups. Group 1 are the people who saw us in person before the pandemic. Their first and last visit was pre-pandemic. Group 2 were people who were seeing us before the pandemic and then transitioned to telemedicine. The majority of those patients transition because they're seeing me long term. So I don't discharge people once they taper opioids. If they see me and they decide they want to continue care with me, I'll follow them long term. And then the anesthesiologist will discharge them and move on to new patients. And then group 3 are people who we're seeing in the telemedicine era. A few of these patients we might have seen in person, but majority is telemedicine visits. And the only difference in the telemedicine era were that patients were less likely to be single, for what that's worth. We also looked at kind of the experience patients had in the PPP. So group 2 are the patients who, again, transitioned from pre-pandemic to during pandemic. More of them are seeing me in psychiatry, and therefore they're having longer treatment duration and more visits. And so you can see that their length of PPP time is about 408 days, so I'm seeing patients over more than 1 year. The things that did change is in the telemedicine era, we were seeing patients on average of almost 7 visits before discharge compared to almost 5. And their length of stay was longer in the telemedicine era in our clinic. It's unclear if that is because of just managing telemedicine or the other factors in the pandemic, or if as clinicians we've kind of changed our ways since 2017 and are seeing people longer. All right. So in terms of outcomes, we were able to show that even though we transitioned to telemedicine, we've essentially kind of had the same outcomes in terms of opioid use. So I'll start there. So in this figure, the teal is going to be their opioid use at their first PPP visit before the pandemic, and orange is their first or their last visit before the pandemic. So all of these patients started and finished our program before March 23rd, 2020. And you can see that there's a statistically significant improvement in their opioid use, going from 108 MME down to about 40 on average when they leave the clinic. And then the middle column is this group 2. So these are patients that, again, started with us before the pandemic and then their last visit was during the pandemic. And even though they're with us for a longer time, this is 69 patients, they still have improvements in their opioid use. And then these are the patients that started with us after the pandemic started. And again, there's improvements in opioids. The 90 MME of the cluster, I think, reflects also changes in opioid prescribing practices that are happening nationwide. We're seeing the same outcomes in terms of pain severity, pain interference. So essentially, before the pandemic, and then that transition pre to during pandemic, and then those patients who see us after pandemic were able to reduce their pain severity and their pain interference significantly. And then in terms of their physical health functioning, so there's a few things to note. So when we were seeing patients in clinic, we could administer the SF-12, which is a proprietary survey, and we had an iPad for that. During the pandemic, when we were telemedicine, we transitioned to the SF-36. So we can't compare the two groups from group 1 to group 3, or we can't compare group 2, the change there. But we can see that the patients do have improved physical functioning both before the pandemic and during. And then actually, during the pandemic, they had a reduction in their mental health functioning in group 3. Another important question is, so patients appreciate the clinic. Our numbers show that we're tapering opioids and reducing pain and improving function, but how are patients doing when they leave? Because one of the biggest fears I have is that we could taper people off opioids, but then maybe they'll just end up right back on them when they leave us. We've seen that in primary care. We've also seen in studies in primary care where people get tapered off opioids and then they don't follow up with outpatient care. So we want to make sure that we're tapering people and not just making our numbers look good, but people are actually having good long-term benefit from the clinic. So we went through and coded each person who saw us for at least 2 visits since 2017 and categorized people as either completing clinic, meaning that patient and provider agree that they were ready for discharge from our clinic, or they didn't necessarily complete the clinic, meaning that they didn't follow up with a recommended appointment, maybe they moved away, maybe they were discharged for not complying with the treatment program. And you can see that about 2/3 of our patients actually complete, or I should say 60% of our patients complete PPP based on patient and provider agreeing that they're ready to go. Those patients who don't complete the program tend to be male, unemployed or disabled, have undergone an orthopedic or trauma surgery, and not surprisingly, they're spending fewer days in our clinic, a median of 77 compared to 98. Also, those patients who complete clinic have better outcomes. They tend to have better reductions in opioid use, better improvements in pain severity, pain interference, catastrophizing, and insomnia. And the question is, what happens to these patients when they leave? So this was us mining the PDMP or CRISP data for Maryland. We are going to be missing data from people who are outside of that CRISP database. But this is data looking at opioid prescriptions that are filled after discharge. So all of these patients, the total of 407, saw us sometime between 2017 and December 2021. This is going to actually exclude patients that I still continue to follow, so there might be patients who are continuing to do well too. And you can see here that average opioid use when patients discharge from the clinic is just above 0, like about 20 MME, and that for the most part, patients continue to sustain that opioid reduction or taper. For those patients who don't complete the clinic as we define it, they tend to kind of have a bump in their opioid use, and then there's still a gradual decline. And essentially at the 10 months after their last PPP visit, there's no difference, statistically significant difference in opioid use between the two groups. And then all of this data is adjusted for age, gender, race, occupation, and insurance. And then this other graph is showing the proportion of patients who have discontinued opioids. So of those who we define as completing clinic successfully, 60% of them have discontinued opioids at discharge, and they continue to kind of stay off opioids completely. Now, for those patients that don't continue clinic with us, it seems like they still continue to reduce their opioids, just kind of at a slower rate. And again, at the about 15-month mark is when there's no difference between the two groups. So based on opioid dose alone, it seems like we're sustaining that opioid taper. So to summarize the first part, Our program is a multimodal, multidisciplinary, coordinated long-term care model that we think is improving recovery after surgery. Patients have described it in overwhelmingly positive details. We had a small N of 26 study qualitatively, but those patients talked about how psychiatric care was welcomed. Using telemedicine, we were able to maintain access and generally have similar outcomes, although potentially a smaller proportion did have multi-D care, meaning they weren't seeing me. And then we think that the PPP is facilitating a significant and sustainable reduction in their opioid use. So now I want to talk about the future of pain medicine. And if this was going to be a really fun, sexy talk, I'd talk about machine learning. But instead, I'm just going to touch upon this and let you know that we've had the good fortune in our group of pairing off with Dr. Casey Taylor and her student, Nidhi Soli, in the School of Engineering here at Johns Hopkins to do some machine learning approaches. And so we use the All of Us research data set to look at factors that predicted acute pain after surgery and then chronic opioid use after surgery. And when we were meeting with them, I said, well, we should include the sleep data in the Fitbit data. And when we did that, we actually found that average time spent asleep and average time spent awake, as well as active minutes, were the highest predictors of acute post-surgical pain up to 3 months after surgery. As well as you can see anxiety and depression fall into that mix. So this is kind of the future, right? Whether we're excited about machine learning and AI or not, this is part of the future of medicine and is still beyond kind of my expertise. But I bring this up because as Dr. Zandi and others have mentioned, right, our data out is only as good as our data in. And so I think one of the things we really need to be thinking about and measuring as we're talking about the opioid epidemic and pain management is how cannabis is going to be affecting the future of pain management. And so Dr. Hanna and I wrote an editorial last year concerned that what we're doing is kind of heading into our own crisis of cannabis, similar to the opioid epidemic. And the truth is, right, is that our patients have access to all different types of cannabis products. And with kind of the legalization and changing landscape, there's been a change in terms of access and use. And so use of cannabis has nearly doubled in almost 2 decades in our country. And for a lot of people, this is exciting because we think, oh, we know in the preclinical animal models that cannabis is helpful for pain, it's a good analgesic, and it's been shown to be opioid sparing in animal models. So maybe we can extend that to human clinical care. And so the question we have to continue to think about is cannabis going to be effective as a substitute or an adjuvant therapy for opioids with potentially less harm? And maybe we could say the data is mixed. So there are certainly studies that show that where cannabis is legalized, medically or recreationally, if you will, that it can reduce the opioid dose requirements that patients are taking. It also reduces their antidepressants and other medicines that they're taking too. And then there was what was described as a very promising study in 2014, an ecological study that showed that where cannabis was legalized medically, there was a 25% reduction in opioid overdose mortality. The concern there is that follow-up studies, which extended that timeline, were not able to repeat those findings. And in fact, other kind of ecological studies show that there might actually be an increase in opioid overdose mortality where cannabis is legalized. So I bring that point up to say that if we need to kind of keep following the literature, right? Because if we stay on the 2014 study, we can get really excited. But with the changing landscape, the research is also evolving. And then work done here in our School of Public Health, as well as elsewhere, has shown that cannabis, whether recreational or medical, does tend to increase risk for non-medical pain reliever misuse or opioid misuse. And that currently Emma McGinty, who was here at Hopkins and is now at Cornell, has shown that medical cannabis laws have not necessarily changed opioid use or non-opioid pain treatment. So when we think about cannabis, we want to think about who's using it, right? And right now, the literature is pretty clear that most patients are using it for recreational purposes, or in this particular study is about a third. But the orange here is recreational use of marijuana. This one is medical use only, and this is the population that's using both. And when we ask people or look at predictive factors of medical cannabis only, and I know I use medical cannabis loosely, but that's just what I'm using based on the literature, people tend to be older, female, not working, have lower income, worse physical and mental health, greater substance use, are using cannabis daily or near daily, and then tend to have chronic diseases. There's another study, if you're looking at the risk of cannabis use disorder and look at individual factors, medical cannabis users compared to recreational users report more difficulty stopping, failing to meet responsibilities, losing time. So they're individually reporting these risk factors for cannabis use disorder. And yet, to call out some of the literature, we're still documenting that medical cannabis patients are using this for symptom alleviation and not necessarily for intoxication, even though this is kind of the same story we talked about with opioids 4 decades earlier, right? If we were to compare side-by-side risk factors for chronic opioid use or opioid abuse, it really mirrors this patient population. So this is a vignette that's in the New England Journal of Medicine from 2018. It talks about a woman with chronic pain with complex regional pain syndrome in her leg and foot, who had had 7 years of disability. They had 2 authors. One person said, yes, prescribe medical marijuana, and the other person said no. And the person who was in support of medical marijuana said it was, cannabis has efficacy, and it can treat chronic pain and allodynia, making it a good choice. And the other person said no to medical marijuana, but did say that cannabis might be safer than long-term opioid therapy, and also said there might be controversy about the addictive potential of cannabis and the risk of cannabis withdrawal syndrome. So this paper's only been cited 4 times, so I'm not saying that this is the end-all be-all, but it does remind me a little bit of that Porter paper from 1980, where we claimed that there was a very low risk of addiction with narcotics. So slightly different, but trying to get to the point, right, that we're publishing these things about marijuana, still maybe not having learned our lesson. So that New England Journal of Medicine paper was 2018. In 2021, the International Association of Pain Medicine, Study of Pain, essentially said that we don't have any high-quality clinical evidence to support the use of cannabis or cannabinoids for pain relief in general. And that's a position statement that's been made similarly by the APA and rheumatology and other societies. Yet, this is a map of the cannabis dispensaries that are available in Maryland. And you can see that they're available everywhere, and that even though we don't have evidence for efficacy, 64% of patients who are getting their medical marijuana license are using it for chronic pain. So use is far outpacing any evidence we have in what we're sharing as clinicians. I will encourage anyone to go to Maryland's website and look how to apply for a medical marijuana license if you haven't already done it. It's actually easier than getting a parking permit in Baltimore. so that, truth be told, our patients can get easy access. I do want to point out that comment about, is there a controversy about addictive potential of cannabis? So I know I'm speaking to a group that we understand that there is the addiction potential, and I just want to focus on SAMHSA has some references from 2011 and 2004 showing that risk is there. So I also question why we're talking about kind of a controversial risk of cannabis use disorder, because we know that is there. Another interesting fact about cannabis is we talk about patients who are using it for medical use only. But here's the challenge, and so this is a study by Alfonso Sandoval Romero down in Wake Forest, who showed that he had students that went out to dispensaries and showed that the percent THC in medical cannabis is actually the same exact percentage as recreational. And unfortunately, the percent of THC is about 20%, whether it's a medicinal or recreational. And the percent of CBD is rather low. And this is true kind of across the board. So most products have more than 15% THC in them. Now, I won't have time to kind of talk about all of that, but I think the importance to realize is the higher percent of THC, the higher risks. And that increases risk of cannabis use disorder and many other factors. But I'll focus on this one study that's from the Netherlands, showing that with percent THC in its cannabis in the Netherlands, there's an increased rate of new admissions for substance use disorder. And interestingly, there is about a 5-year lag showing that as the percent THC increases, so do the numbers of treatments, new treatment admissions to substance use, and that's even for controlling for other substance use treatments and demographic factors. So as we're increasing our cannabis use access and potency, we're going to see more admissions for cannabis use disorder. So with that said, one of my goals in clinic is to, again, make sure that we're doing best by our patients and using best care practices. So we've been collecting cannabis report data from our patients in the clinic because I want to be able to actually use evidence-based medicine to say that these are my reasons that I'm worried about your cannabis use. And so 50% of our patients say they've never used cannabis, 27.5% said they've used cannabis but not in the past 30 days before their first PPP visit, and about 22% use cannabis within 30 days of their first PPP visit. And our demographics are a little bit different than what we're seeing in the literature. Our patients are younger, male, single, unemployed, which I think speaks to probably the recreational use in Baltimore City. And we're finding no association of opioids or pain compared to cannabis use, at least when patients are coming into the clinic. Interestingly, we're looking at concordance rates too between what's measured in self-report, which we're collecting through REDCap, and then what's documented as urinary toxicology screens in our EMR, and then in the social history tab of EMR. And our EMR data and urine tox screens have pretty high concordance of 82%. And our electronic records for self-report and urine tox screens for self-report are relatively high at about 70% or 60%. But when patients tend to when there's a discordance between those reporting, patients are self-reporting their cannabis use more than we're detecting it as clinicians. We're also seeing that most of our patients are using cannabis recreationally. Only 1/5 are using it for medical purposes. Most patients are using for pain compared to sleep, anxiety, depression, or other reasons. Most patients are still using dried flowers. And only 10% of patients are reportedly wanting a high THC, low CBD ratio. I always think it's important to point out, here we have 12.4%. Sometimes it's as high as a third or 50% of patients that don't even know what ratio they're using or what products they're using. So with that said, in the interest of saving time for questions, in terms of cannabis use, to my knowledge, we're collecting kind of the first comprehensive evaluation of cannabis use among a surgical pain population. We've found that patients are willing to report their cannabis use. They're doing that, and we're detecting it more through self-report than in the medical record. Hopefully I've made a case that we need to talk to our patients about cannabis for pain because we don't have any data on its efficacy yet. And this question of is it going to be an effective substitute or adjuvant for opioids? My short answer is no, but I think we're going to be spending the next few decades trying to address this and dealing with it. And so this is a sign near where I live that said, you can't spell healthcare without THC. So similar to, I guess, you can't spell, United States without us, and you can't think about pain if it's not a fifth vital sense. So I think hopefully I'll have some more data in the future about what cannabis use is, like what that's happening or how that's affecting our patients. And for now, thank you for the opportunity to present. And this can't be done without a team of people, and I want to throw a special shout out to our medical students, Divya Manoharan, Meher Kalket, and Lorenzo Salone, who've been doing some excellent research with us. Thank you.
Thanks, Dr. Speed. Very, very interesting. This issue of cannabis is a fascinating and important one. And you made a number of good points about it. One thing it reminds me of is all that we've learned about how the opioid industry in the last couple of decades have made such a push to persuade people of the importance of using opioids and the relative lack of problems associated with it. I guess I'm wondering, how much is the cannabis industry doing something similar, that is pushing messages about how effective cannabis is to treat pain in the absence of any clear data supporting it?
So I think it's doing a lot. In the interest of a 30-minute talk, I had to take out a lot of slides about that, right? But when we think about OxyContin and Purdue and what was happening decades ago, we were talking about like $1 million industry. And now with cannabis, we're talking about $1 billion like direct-to-consumer industry. And certainly, I mean, there's a lot of patient advocacy, right, of patients who think that the cannabis is helping manage their pain, and it looks like the data is really helping them maybe sleep or causing that euphoria. So what I think we're doing is, right, helping people numb themselves like they were doing with opioids. And certainly the billion-dollar cannabis market is happy to support that. And unfortunately, in most states, the rules with kind of medical cannabis just require you filling out an online form, right? And there are providers who are able to just prescribe cannabis, and they're not doing anything else, right? So certainly there's this consumer market that we're dealing with now, which is just bigger and very different than opioids.
Absolutely. Yeah. Other folks have questions? Yes. Dr. Prince.
Thanks so much, Dr. Speed, for a great talk, and it's so exciting to hear about your innovative and successful clinic. I was wondering if you could tell us any more about how it's decided that a patient would see you, the psychiatrist, in your clinic, as opposed to only seeing the anesthesia docs.
It's a great question. So the question is how do we decide who's going to see psychiatry versus just anesthesia in the clinic? And the answer is that we intentionally never standardized it by cutoff scores because I didn't want to stigmatize people initially when we started using these different pain-reported outcomes. So there's kind of three ways that I generally say is my colleagues tend to use the pain catastrophizing score or a very poor mental health score on the SF-36 or a really high insomnia severity score as kind of their markers. Or if they can see that someone just seems very clinically depressed, sometimes that crying signal, right? And when they're crying a lot in clinic, kind of tends to be the factors. I would say the other is if patients are starting to have a really hard time tapering off opioids, and then that's kind of when I see them at the end of clinic. What we'd like to do is kind of come up with a more systematic way to standardize that now that we've been going and doing this for 5 years. But right now everything is kind of clinical judgment, and I will say my colleagues work really hard to convince patients to see me sometimes when they don't want to. So.
Great, thank you. Other folks have questions? Yes, Dr. Walensky.
Thank you. That was, I echo Dr. Prince's sentiments. It was a really excellent talk. I was curious about if you had seen thoughts, people coming out into the perioperative clinic who are being transitioned onto buprenorphine or Suboxone for chronic pain. I know a lot of times on the addiction consult service, we see many people requesting that individuals be transitioned onto buprenorphine rather than their short oxycodone or high-dose morphine. And I don't know, I was just curious if you had seen that at all coming into the perioperative clinic, or if you had advice and thoughts on whether that should be a reasonable strategy for chronic pain, or are we running into all
Thank you. Thanks. Yeah, go ahead.
Yes, the question about transitioning patients to buprenorphine or Suboxone for chronic pain. So about 10% of our patients meet criteria for opioid use disorder, and I would say about 10% of those patients end up on Suboxone or methadone. My colleagues, interestingly enough, tend to see the OUD patients more than I do and tend to manage the buprenorphine. And generally speaking, the idea is to either use buprenorphine for tapering, but to actually help patients come off buprenorphine once they're like kind of in that chronic post-op period. So it's not, if they have true opioid use disorder, they do stay on Suboxone or they go to methadone clinic. But for those patients who are having more difficulty with their taper and they transition to buprenorphine, but don't necessarily meet true requirement for OUD, they do end up getting tapered off, so they're not on a long-term opioid.
We're just about out of time. I'll point out Dr. Walensky's grand rounds next month, I think, is going to focus on cannabis and its relationship to psychiatric illness, so we'll have a chance to continue that aspect of the discussion. But thanks so much, Dr. Speed, for a great round, really good.